Good morning, everyone. So hopefully you're having a good day wherever you are right now. So we're on to our second last video for the ECG series, which is on AV blocks under conditions. So I'll share the PowerPoint. And again, I have examples at the end, so feel free to jump to those if you want to see examples. Okay, so our outline for today is AV node blocks and their intervals, and review of intervals actually for like P, Q, or ST. Other conditions like hyper and hypokalemia, which isn't really tested in our course very much, but we'll just cover it briefly. Pericarditis, which would be good to know, and pulmonary embolism. And then we'll do practice with week 5 supplemental ECGs. For the cheat sheet that we'll be going to have expanding on today, we're going to be looking at this section, which is underneath the 3rd page, additional helpful diagnostic criteria, AV blocks. And then we're also going to be looking at acute pericarditis and right heart strain. So this doesn't especially build a whole lot on that rare steak barbecue with Sterling approach. However, it is things that you have to look for when you're reading the ECG. Quick refresher on intervals, the PR intervals. So from the start of the P to the start of the QRS, ST segments right after the QRS and right before the T wave. The T wave is that blue part. So when we're talking about AV node blocks, it's generally like a lengthening or slowing of the heart rate. So if it's a primary block, the PR interval gets longer, so it gets larger than 1. It's usually 0.2 of a second what I go with, so 1 large box. Secondary block, if basically means there's going to be a dropped QRS, but it's not ridiculously dropped, like it's in a pattern. If it's longer drop, then it's winky back, so it goes P space QRS, P longer space QRS, P even longer space QRS, so 0.18 seconds, 0.25 seconds, and then the QRS gets dropped. And you just keep repeating that. Versus Mobitz type 2 would be, there's P's, like it goes P normal length QRS, P normal length QRS, but then P and the QRS is just dropped. So when you're seeing these dropped QRSs, you kind of need to pay attention. Is that P getting longer before you drop the QRS? And 3rd degree block is that they're completely separate. So it goes P, and then the P's are regular intervals, but the QRSs are not linked up, and the QRSs are regular intervals to each other. So just showing that again, a little bit more detail. So with the 1st degree, you're looking for a long PR interval and a 1-to-1 relationship. For 2nd degree winky back or Mobitz 1, you're looking for an increasingly long PR interval with a constant ratio of dropped QRSs. So you see this P gets longer, and then dropped, long, and then short, longer, so on and so forth. 2nd degree, which Mobitz 2. So you're going to see constant PR intervals. So you can see that's nice and short, drop, short, drop, or no drop, but short. So it can be hard to differentiate this pattern. So if it's a 2-to-1 Mobitz 2, which is what we're looking at here, it can be hard to differentiate from a 2-to-1 pattern with Mobitz 1 because you can't really see if the PR interval is getting longer, and they wouldn't ask you a question to that degree. 3rd degree, you can see the P's are a constant distance apart, sometimes overlapping with that T wave. QRSs are also a constant distance apart, and you might see a weird QRS because you're not using the Purkinje fibers or bundle of His, and also it's going to be a slower rhythm than the atria. This is just a table summarizing what we just talked about. You can look through it if you'd like. And same with this. This is just talking about the PR interval, and you can just look through that if you'd like. And then last thing, this is just the QT intervals. And basically the biggest thing is if the QT interval is prolonged, the person's at risk for something like torsades de pointes. So hyper and hypokalemia. So if it's hypokalemia, the way I can remember it is it's going to be a flat T wave because it's hypo. And then there's other things like a prolonged PR interval and some ST depression. Over here, this picture kind of shows it nicely. You see this nice long interval, QRS long, and then a T wave, but it's kind of flatter. Hyperkalemia is different in the sense that it has a really tall P wave. It's tall and peaked. And there's still the ST depression, so that doesn't differentiate much. So you can see this P, it's a little bit smaller, wide QRS, and then T. So the T is spiked. So hyperkalemia has a big T. This is just a picture showing additional things. Just focusing though on the hyperkalemia, see this nice tall peaked T wave, and then hypokalemia, it's going to have severe hyperkalemia, and then hypokalemia, you're going to have a very flat T wave. And then of course, looking at the QRS is wider in hyperkalemia. So those are basically the things you'd see, but you'd probably be also getting blood work on the person. Pericarditis is actually probably one of the more important ones that we're talking about in this session. So if you're seeing this concave smile or hockey stick, you need to be considering pericarditis if it's in a lot of leads. It's almost every single one of them. It's going to be in the same direction as the QRS complex. So if it's mostly an R wave, it's going to be mostly going up. If it's mostly an S wave, it's mostly going down. The PR is depressed, so this is actually going to be low. And then AVR shows the opposite. So the ST is depressed, and then it's going to be a concave shape. And when you see it, it stands out. So yeah, if we look at this, so you can see in the lateral leads, it's elevated. It's got this concave shape, elevated, concave shape. Let's check over V5, V6. Yeah, same thing. Lead 2, lead 3, not so much. Lead AVF, yeah, it's still there, elevated, and with that kind of concave T. And then if we went through V1, 2, 3, 4, 5, 6, you can see almost all of them have the concave, and it's going up with an ST elevation. And AVR is reverse. So it's got ST depression with that concave shape. So if you see almost every single lead with a concave T and ST elevation, it's probably not like just a massive heart attack. It's probably pericarditis. Last thing, this is just kind of in here just for completeness. So you don't have to memorize it. It's kind of important though. So pulmonary embolism, essentially what happens is they get a really big S wave in lead 1, a Q wave in lead 3, and an inverted T. So lead 3 has a Q and an inverted T, and then lead 2 has an S wave. All right, so we're already on to practice. So this is the sections from the ECG cheat sheet, which I had talked about before. So first degree lengthening PR interval, Mobitz 1 or Wenke back. PR is progressively longer with dropped QRSs. Mobitz 2 is dropped QRSs, but the PR stays constant. Third degree, they're completely dissociated. Wolf Parkinson White, we had talked about before. I guess I just included it here. Acute pericarditis, looking for that concave ST elevation, T wave across almost all the leads with AVR showing the opposite. Pulmonary embolism, which I don't have any examples on, just a spoiler there. S1, Q3, and I think that was actually T3, not T4. Yeah, that looks right. Okay. All right, so let's do some practice questions. So go ahead and challenge it for yourself. This is question 17, and then we'll do it here. So right. So it looks like I had a rate of about 100. And it looks like the rate might not be constant. Looks like this is 1, 2, 3 boxes. This is like 1, 2, 3, almost, yeah, 4. 1, 2, 3, 4. So kind of odd, looks irregular. Irregular. Axis up and up, so axis is normal. Rhythm, I'm already thinking AFib because of the rate. It's kind of weird. Yeah, and this is looking like a wavy baseline. Wavy, yeah, it's a wavy baseline. So we're going to go with AFib. Intervals, PR doesn't look like it has an interval, especially if it's AFib. So no PR. QRS looks normal. Nice and narrow, spiky. T waves, that looks normal. Okay. So now we can check for hypertrophy. Yeah, I don't really like. I'm not going to see atrial hypertrophy. This looks a little bit like left ventricular hypertrophy with that 1, 2, 3, and then maybe 1, 2, 3, 4, 5. Looks like then left ventricular hypertrophy. I don't think right. It's not high enough for lead V1. And then we're going to check our lateral leads for Q waves, Qs. Nope, no Qs. I check for ST. It looks a little bit depressed. Yeah, ST depression. T waves, inverted, 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 inverted. Here, Q waves, none, none, none. So no Qs. ST looks pretty normal. And then T waves. This one might be inverted. Up, up. Yeah, I'll just say normal T's. Again, didn't see two changes. So precordial, especially focusing on B1 4 and then the R waves. So precordials, Qs, nope, 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 no Qs. ST looks about normal. Normal, normal. That one looks a little bit depressed. So just going to make a note, V4 depression up here. Normal STs anteriorly otherwise. And then the T waves, it's perhaps is a U wave, like a T and then a U, because it doesn't look like a P. Yeah, so I think it's just mostly normal T waves. So interpretation. Let's do, so no Qs, ST depression, the 4 plus lateral leads, inverted T waves, lateral. All right, so we'll take that interpretation, take this, and let's check how we did. Okay, so I had a rate about 100. I probably could have been a little bit more specific and divided it by 8 seconds and then times it, but I didn't. Irregularly irregular, yeah, that's probably the big thing to get. No clear P's. Grade atrial fib, got that. Rate 75, okay. Normal intervals, Left ventricular hypertrophy, yeah. No major Qs. Anterior lateral ST depression B 4 through 6. And 1 in AVL. So yeah, we got that ST depression B4 in the lateral leads and T inversions. So inverted T waves lateral, like U waves. So T, U, T, U, T, U, T, U. So U waves V1 through 4. So the summary is 8 fib, 75 beats per minute, left ventricular hypertrophy with strain. I guess with the hockey sticking there, yeah. Anterior lateral STT changes. Yeah, so you can see that concave shape, so that's strain. All right, so question 41. So this is the first part. So go ahead and challenge it. I'm going to start over here. So let's check our rate. I'm just going to count it 1, 2, 3, 4, 5, 6, 7, 8, 9. So 9. So it's a little bit more. I'm just going to say it's like 65 or something. I know it's higher than 60. If it's 8 over 9, if it's 9 over 8, it's going to be a little bit more than 60. Axis. Up, that's down. I'm going to say normal axis. Let's look at rhythm. So let's look at a very long PR interval. So you see there's a P wave and then there's QRS, T, P wave, QRS, T, P, QRS, T. So I think the rhythm, it's sinus, but AV1 block. Intervals, PR is long. QRS is wide. If you look over here, that's a wide QRS. Same with this. Same with that. QT normal, less than half. Hypertrophy. Left atrial enlargement, not large enough to look like it. Right atrial, definitely not. Left ventricular, nope. Right ventricular, probably not. This is probably just the bundle branch block, so no. So none. And then let's do our bundle branch blocks. So it looks like a right bundle branch block with the M up there and the wide QRS. So just a right bundle branch block there. And then checking through our, Qs, STs, Ts. So Q waves and lateral leads, none. So no Qs. STs. This could be a little bit, yeah, it looks depressed. So ST depression. And T wave. It's normal there, but it looks, yeah, it looks like normal T waves. Okay, so inferior. I don't see any, well, yeah, probably not a Q. This looks like a Q. That looks like a Q. So we got Qs, ST, elevation. It's gonna put STEMI for short, and then T wave. It looks like the T wave is normal. So normal T. And then precordial. Well, you can also say anterior if you want. Just make sure you always check that R wave progression. So T inversions, and it looks like ST depressions through the anterior leads. But there's no Qs. So ST depression, T inversion, V1 to 3. And this is likely from the right bundle branch block, just strain on the heart. So our interp. So right bundle branch block, interior ST depression and T inversion. Inferior Q wave with ST elevation and lateral ST depression. So let's have a look, see how we did. All right, so we'll just read it, probably just do it off memory here. Science rate about 65, yeah. Normal axis, yeah, said that too. A severe AV1 delay, you can see it there along PR for sure. Right bundle branch block, yeah, no hypertrophy, same thing. Inferior Qs, that was over here, yeah. Inferior ST elevation, got that. V1 through 4 STT depression, and it says from the right bundle branch block, so we got that. ST depression and 1 in AVL, yeah, we said lateral leads had ST depression. And then, so their interpretation is severe science AV1 block, right bundle branch block, inferior Qs and STEMI with a query lateral ischemia. Same patient, next part, so 41.2 is what I put here. So go ahead and start. I'll start here, so rate 1, 2, 3, 4, 5, 6, 7, so 7, so it's less than 60, so less than 60 I'll just put. Axis is normal. Rhythm. Okay, so we see a like dropped QRS, so there's a QRS missing RRR, missing RR, missing R. So we have to decide what type of, so it's an AV secondary block, but now we have to decide, is it Mobitz 1, it's a longer and longer PR, or is it Mobitz 2 with just like normal PR every time, but a dropped QRS here and there. So lead, we can try lead, I like lead 2 here, so this looks like PR. Let's go, this looks like about 2 boxes. And then we have 2 boxes. I'm actually just going to get a line. So that way I can compare it, because this graph is not very high quality. So if I look at this, this is that line. If I compare it to here, looks about the same as compared to the next one. It definitely got longer there. So if that's the P wave just on the left side of that bar, and that's the QRS, it's now wider than the line. So let's try it again over here, because this is the dropped, this is the P with the dropped QRS. So yeah, it's within that line. It's a little bit longer, but barely. Yeah, it's definitely longer, not by much, but a little bit, and dropped. So I think this is our best bet right here, because it looks like this is within it, this is at it, and this is longer than it. So most likely, if it's getting a longer and longer PR, this is winky back. I spelled that right. All right, so we did axis, now let's do our intervals. So PR, progressively longer. QRS is wide, it's still got the right bundle branch block. T, or QT is normal. And then I can just look at that right bundle branch block. It's the same guy, but just different reading. And then checking our laterals. No Q, no Q. V5 and V6, no Q. ST. Depression. Oh, that one's not really depressed, but I'll put it for the rest. So ST depression. T's up. Inverted. I'm just going to say normal T's. Inferior. Q's, yes, still has the inferior Q's. ST elevation, that hasn't changed. So this reading was obviously taken not too long after the previous one. So ST elevation, and with normal T's. And then we could do the precordials, and we see the right bundle branch block pattern. And we already interpreted it last time, and this is already showing up to be the same. So I think the biggest thing that we're focusing on is that now it's a winky back pattern. So let's just have a look. Sinus rate about 85. It says we're looking at the, oh, this might be looking at a rate of 85 of atria, because the ventricles are definitely not contracting at that rate. So normal axis, yeah, so the same thing. Secondary AV block going 4 to 3 and then 3 to 2, blue arrow in the image, winky back. So this is a progressively longer PR interval. I think it's most obvious with this one here. This slide was not quite as clear. So I think this guy right here, this P to QRS, it kind of shows you it's getting longer. And the rest of the findings is the same as the previous. So winky back, right bundle branch block, inferior Q STEMI lateral ischemia. Right, next question, question 61. So go ahead and start. I'll start here. So rate, so let's go 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11. So 66 rate if it's a 10-second ECG, 300, 100, 300, 150, 100, 75. And it's a little bit lower than 75, so that sounds right. Axis, up, normal. Rhythm, well, if I see a big spike, I know it's a pacemaker, so pacemaker. And QRS looks wide. It's still pointy, but it just has this kind of look to it. It's almost one box, so it's a wide QRS. So if it's a wide QRS, then we know that we're already thinking about the bundle branch blocks, and the PR is like non-existent because it's a pacemaker. So we could say normal PR or just like pacemaker PR, I guess. And then QT is normal. And so if it's got a bundled branch pattern, generally just this kind of knowledge piece, ventricles are like, pacemakers are usually paced with the right ventricle if they're pacing through it. So which means essentially just the rule of thumb is if it's in the right ventricle, it shows up like a left bundle branch block because the right ventricle goes first, and then it comes around to the left ventricle. So it's as if there's a delay on the left side, which is the left bundle branch block. And just based on, again, just kind of knowledge, left bundle branch blocks you don't interpret. So left bundle branch block equals done. because you're not going to check your QRS and whatnot. So we can just double check for hypertrophy. Atrial we're not going to probably see, and ventricular it doesn't look like there's any, so no hypertrophy. All right, so let's have a look at what they said. Sinus 60, I had 66, similar. Dissociated ventricular pacing. The Ferrous, the pacemaker. Third degree AV block. Oh, I totally forgot to look for the P waves. So if we go back, so we see a P, there's a P, there's a P, there's a P, there's a P. And then it kind of disappears. Oh, there's a P again, P, and then the QRSs are all at the same distance. So obviously the atria are running on their own system, and then we could infer from that now that ventricles are getting paced. So third degree AV block, complete heart block, can't interpret any further. So if it's pacing the right ventricle, then it's a left bundle branch block essentially. And so we don't do QRSTs. All right, so that's all. Hopefully that was helpful, and have a good day.